I'm Dr. Feinberg. I'm going to be performing electrodiagnostic studies on a patient today. I'm the director of the Physiatry Electrodiagnostic Lab, and we're performing the study to determine if this patient has any neurological injury or muscular dysfunction or disorders. And we're going to start off by performing the nerve conduction studies. When we do an electrodiagnostic study, there's two parts of the study that we perform. There's the nerve conduction studies, and then there's the EMG portion, or the electromyographic component of the test. For the first part of the test, the nerve conduction studies, we're first going to check the median nerve, and we test that nerve by stimulating the nerve with little electric shocks. The first one will be done in the region of the wrist, right here, and then after I've recorded that on the screen and saved it, then I will be testing the nerve higher up in the elbow, and then getting a velocity of conduction. So we'll start off here, a little lower down, so you see what this feels like. We are now going to stimulate the same nerve, but at a different point. We'll stimulate the nerve in the elbow, and you'll feel a similar type of shock. Now that I have these two responses, I'll plug in a distance, which I will get by just measuring the distance from point A to point B. And based on that distance and plugging that into the computer, I will get a conduction velocity. This is the median motor response, and this is how it looks on the screen. This is the first response at the wrist. This is the second response at the elbow. They should almost look identical in size, just one happens later than the other. That's the distal latency. If that were prolonged and abnormal, that might suggest that the patient had carpal tunnel syndrome. So now I'm testing the median nerve, and as I mentioned earlier, this is the same nerve that we test for and is involved in patients who have carpal tunnel syndrome. And we get a response here on the screen. Again, I then stimulate at the wrist, and I get a response here on the screen. This is a sensory response at the palm and at the wrist, and again we get a conduction velocity from this point to this point, and if we're slow, this is actually 53 meters per second, then the patient might have carpal tunnel syndrome. Okay, so now we're going to perform the second part of the test, the needle exam, which is the EMG part. And what I've just done is opened up a monopolar needle. These are disposable. They're used one time for each patient, and then they're disposed. So at rest, we should be silent. And after I've sampled different areas of the muscle, I then will have the patient contract the muscle, and we'll look at what we call the motor units. So we'll have you lift this finger up a little, push up harder, harder, hard as you can. Good. Okay. We'll take the needle out. Rarely is there any bleeding because these are very small punctures. And that was normal. And what we call recruitment, the recruitment of the motor units was normal as well. And I should say that there is minimal risk for infection. Really very few contraindications for doing the needle exam. Even patients who are anticoagulated on Coumadin or other forms of anticoagulation can undergo the test, and because there's very minimal bleeding and the needle is so small, so that's not usually a significant factor. I will add, though, that with the electrical stimulation part, patients who have a defibrillator unit must turn that off when we're performing the nerve conduction studies. So now we're going to check one of the rotator cuff muscles. The rotator cuff is innervated by the suprascapular nerve, and with certain athletes and certain patients, the suprascapular nerve can be injured. And so in patients who have shoulder pain and weakness, this is one of the muscles that we'll check. And I'm actually going to check the infraspinatus muscle, which is right on the outside of the shoulder blade, or the scapula. And I go right into the muscle, and you felt that? Yes. Now we're going to check the trapezius muscle. One of the reasons we're performing this test is because he has what we call scapular winging. The shoulder blade sticks out sometimes, and several muscles can be responsible for that. The trapezius muscle is one of them. That's innervated by the spinal accessory nerve. The other muscle that I had checked earlier was the serratus anterior, that we did not actually demonstrate, but that can also cause winging if that muscle is not working. So here's the trapezius. So we've completed the electrodiagnostic test. We did the nerve conduction studies and we did the EMG portion of it. This particular patient, the studies were normal. There should be no adverse reactions to the test. Sometimes there's a little muscle soreness in some of the muscles that we inserted the needle to. As you could see during the test, there was no bleeding at all. And do you have any discomfort now, or any?
No.
You don't notice anything
No.
after the test? You don't have any significant pain anywhere?
No.
So I think that is pretty typical of what the test is like in most situations. Some tests are longer. They require more extensive testing depending on the disorder that we're looking for. But it's very helpful in identifying these types of problems, in either determining that the problem exists or it doesn't exist and quantifying this.